Probably the most critical thing in establishing a treatment regimen for a patient is understand the risk factors associated with each individual patient. As I mentioned earlier, patients who have 11q or 17p deletions and those who have complex karyotypes and IGHV are much higher risk for progression and early mortality. So paying for those tests to understand which therapy is most appropriate for that patient are critical. Remarkably, or maybe not, remarkably, the cost of that diagnostic intervention is a pittance in comparison to the cost of the therapies. So it's in everyone's interest, the patient's, providers, and the payer's interest, to ensure that we understand what those risk factors are to ensure that we have the patient on the most appropriate therapy. For example, for very low-risk patients, those under age 65, who don't have any deletions, who have a normal karyotype, who don't have mutations or have multiple mutations in IGHV, those patients may be appropriate for FCR, fludarabine, cyclophosphamide, and Rituxan, whereas those who have more complex risk factors, such as multiple comorbidities and multiple unmutated IGHV and 17p deletions, those patients might be more appropriate for molecularly targeted therapies such as Imbruvica. The evolution of the NCCN guidelines have really helped payers and providers alike identify what optimal therapy is for a given patient. For example, in first-line treatment-naive patients with CLL, historically we've used a combination of chemotherapy and Rituxan. There now is approved a number of different therapies, including ibrutinib alone. But just as importantly, the NCCN has helped identify what preferred regimens are and then what alternate therapies are. So it's gone from what I called a 13-lane highway to where you could use any of those, and they didn't specify which were optimal, to now 2 or 3 or 4 preferred regimens in first-line treatment-naive patients. And then likewise in relapse refractory patients, first-line therapy could include ibrutinib alone or a combination of newer agents such as Idelig and rituximab or venetoclax and Rituxan. More complicated then is, or maybe less so complicated, are patients who have 17p deletions, where ibrutinib is the only category 1 NCCN recommendation, followed by some of the Rituxan-containing regimens with venetoclax or Idelig after that.